Thank you very much, Ori. I'm very grateful to you and all of the organizers for arranging for this conference. And I'm really deeply honored to be here. I've never been the honored guest and never had a conference organized in my honor. So I'm really deeply touched. And all the more because it's here in my spiritual homeland. I'm not sure exactly how I'm going to advance the slides. Oh, okay. So the topic of this first talk has to do with helping people get in touch with their emotions and the difficulties that many people have. To kind of illustrate what we're talking about, I have this cartoon. It says, "Look, call it denial if you like, but I think what goes on in my personal life is none of my own damn business." Okay. And that's a nice joke, but it's actually really no laughing matter. It's really very serious and often, sometimes a life-threatening situation. So I'm going to divide this into 4 basic sections. I'm going to start off with the clinical case, which is not particularly special, but the kind of thing that you see every day. We'll then start going into the theory of emotional awareness and levels of emotional awareness, talk about the theory, talk about some of the evidence supporting it, and then this concept of affective agnosia, which is my term for, well, it means not knowing how you feel. And this is what I call extremely low emotional awareness. And we'll talk about clinical applications. So part of my background is that I've, for 5 years, ran a consultation liaison psychiatry service at a university medical center. And this was a consultation that we did one day on a 41-year-old unmarried woman who was hospitalized for workup of abdominal pain. Abdominal ultrasound and endoscopy were negative, and a psychiatric consultation was requested. So the patient reported that persistent pain had been present for 3 months, and we asked her, did anything happen, around 3 months ago that might have contributed to your pain? And she said no. But we proceeded to take a psychosocial history, particularly over the previous couple of years, and it turned out that her mother had died 3 months previously, and the pain had started shortly thereafter. And we said, oh, when we asked you, did anything happen in relation to the pain? You didn't mention that. You said, well, I don't think it's related to the pain at all. It turned out that this was her adoptive mother who took her in at the age of 8. And she was adopted because her biological parents were alcohol dependent and were physically abusive. She was placed in a series of foster homes until she finally was adopted by this woman. So she really had a difficult upbringing. Her mother, adoptive mother, was very kind and nurturing, and she suffered from diabetes and peripheral vascular disease. And during the last 5 years of the mother's life, the patient cared for her on a daily basis. Now, 1 week before the mother's death, after a medical setback, the patient contemplated the possibility of her mother's death and was overwhelmed with a feeling of grief. A week later, the mother died of a GI vascular obstruction. And since her mother's death, the patient has experienced no feelings of grief or sadness of any kind, but she has pain, abdominal pain. In addition to the pain, she suffered from anhedonia, had neurovegetative symptoms of depression, and met criteria for major depressive disorder. Does this seem like a common kind of case that you see? Yeah. Okay. So why did this patient not experience grief? Okay. So one possibility is that there was just a weak emotional response. She really didn't care that much. Okay. So that's why she doesn't have grief. That's probably not the case, right? She was overwhelmed with feeling of grief the week before. Here's another possibility. It's a strong response experienced in a differentiated manner, but she has trouble putting it into words or cognitively processing it. In other words, she's really experiencing a lot of grief, but she just doesn't have the words to describe it. Probably, I don't think so, right? For one thing, she didn't relate her pain at all, or whatever she was feeling, the state she was in, to the death of her mother. She didn't see it as all relevant in her experience. All right, third possibility. The experience can be verbalized, but it is unwanted and excluded from consciousness due to defenses or repression. Now, I would think that this is the way you'd typically think about it, that she's got grief and it's defended against and it's under repression, which means that it's a kind of differentiated feeling and she really knows how she feels, but it's defended against. And that is a viable hypothesis to keep in mind. But a main thing that I want to convey in this talk is the distinction between defense and deficit, okay? And sometimes they go together. Sometimes there's a deficit that contributes to the defenses. And I want to bring out this deficit idea. That's the main point of this talk. And so it comes down to this section here, a strong emotional response that's not experienced. She doesn't perceive it. It's not differentiated because either the state response is too strong, so this might be a one-time thing. This is a trait characteristic of the individual. She never experiences emotion at all. That's probably not true because the week before she had overwhelming feeling of grief. But how about this? The individual has a low tolerance. It's a state-by-trait interaction. There's something about her rough upbringing, the abuse that she had, that makes it difficult for her to process emotions. And then when it's especially strong, it's hard for her to experience it as a feeling, and it's a bodily state. And I will try to develop this idea further. So, what are the emotional and cognitive consequences of trauma? Trauma, by definition, is overwhelming. It's exceeding the child's coping capacity. And experiences are often not shared with others. If the parent is a perpetrator, which was the case in this woman's history, it's a double whammy because not only is it abuse, but also there's the lack of support from the parenting figure. So the child is on its own, and adjustments are made to minimize emotional distress. How do they do that? Well, they become pessimistic. They no longer expect good things. They think that it's all their fault, so they're perfectionistic. They're hesitant to engage with people, so they become withdrawn. And they focus their attention externally, not internally, because to do so might be painful. These adjustments were adaptive in the original context, but are maladaptive later in life. So, how do we know that this might be the case? Well, it's actually a relatively understudied phenomenon, but we can look at the example of children from Romanian orphanages who had their physical needs taken care of, but not emotional needs at all. And a study was done of Romanian orphans who came to the UK at the age of by the age of 3.5 years. And it was found that they had impaired theory of mind and executive function relative to other Romanian or British adoptees tested at age 11 years. And they found that the longer the children had been in the orphanages, the more impaired they were, as you see here. Most impaired, they'd been in orphanages for 2 years or longer. Least impaired, they'd been in the orphanages for 6 months or less. Okay, so what kind of conceptual tools do we have to describe this condition, this deficit? And the term alexithymia, how many people have heard of the term alexithymia? Oh, very good. Wow. That's also a highlight and a special experience. I've never had so many people say that they knew the term alexithymia before. Okay. It's from the Greek, it means lacking words for emotion. But even when the term was conceptualized and coined in 1972 by Sithnios and Namaya, the question was, are they lacking words for feelings, which is what the term means, or are they lacking feelings? They said in a paper in 1970, these patients manifested either a total unawareness of feelings or an almost complete incapacity to put into words what they were experiencing. So, we think about the case that I presented. She seemed to be totally unaware of the feeling of grief. And I just wanted to put into context that in 1948, Jürgen Rusch had written a seminal paper called The Infantile Personality, the Core Problem of Psychosomatic Medicine, which he said was an impairment in the ability to symbolize emotional experience. Okay, so that was 1948. I guess Bion even maybe preceded that. But also the concept of theory of mind really wasn't formulated until 1978, and here we're talking 1972. So what I'm going to try to introduce in this talk is the idea that theory of mind and mentalization capacity is important to consider in relation to alexithymia. Alexithymia is now defined, as I said, lack of words for emotion. It involves difficulty identifying feelings, difficulty describing feelings, and externally oriented thinking. And the leading measure of alexithymia is the Toronto Alexithymia Scale, which is a 20-item self-report scale, where people are asked to basically report on how emotionally aware they are. Things like, do you agree or disagree? I am often confused about what emotions I am feeling. It's difficult for me to find the right words for my feelings. So it actually requires a fair amount of awareness to be able to accurately respond to this. And so I have said in print that the scale is especially valid if you don't have alexithymia. I do want to say that there are a lot of findings with the Toronto Alexithymia Scale, and I think that it's worth taking a look at, but I think you have to be aware of the limitations of the TS-20, and I think there's room for other ways of measuring it, particularly if we're interested in the severe form of alexithymia when people really seem to not have feelings. And so we kind of started from scratch in trying to alexithymia was thought of as a developmental deficit, but the nature of the developmental process for which there was a deficit hadn't been described. So one of the first things I did in my career was to write a theoretical article about levels of emotional awareness with my first mentor, Gary Schwartz, and this was published, hard to believe, over 30 years ago in the American Journal of Psychiatry. And this theory about emotional awareness really represented an integration of the work of these two smokers here, Sigmund Freud and Jean Piaget, father of cognitive development, father of psychoanalysis. So what we said is that the ability to be aware of one's own emotions is a cognitive skill like any other, and this ability develops over time. Similar to Piaget's stages of cognitive development, developmental transformations occur in the capacity to be aware of one's own feelings. According to Piaget, cognition becomes more differentiated and integrated with development, and the higher the level of emotional awareness, the greater the differentiation, integration, and desomatization of emotional experience and expression. So by desomatization, we mean that emotion starts as a bodily response, but then it evolves into differentiated feelings. The bodily response doesn't go away, but it's not exclusively a bodily response. But one way of understanding somatization is that you're just getting the bodily response of emotion without the conceptualization of it as a feeling. So we described 5 levels of emotional awareness following Piaget's stages of cognitive development. And we call it levels because we know that emotions fluctuate all the time. So emotions start off in the body, bodily sensations, or this is the autonomic neuroendocrine aspects of emotional responding, action tendencies, gestures, facial expressions, even scripts and procedures. Then level 3 is, and we call these implicit, because it's not yet a differentiated feeling, but at level 3, conceptualized as unidimensional emotional experience, when you can put a word to it, a specific emotion concept like happy, sad, anger, or fear. That's level 3, one emotion. And we're talking about how people respond in situations. So you might have 2 emotions at the same time. I use the example of when my daughter graduated from high school. I felt happy and sad at the same time. That was level 4, a blend of feelings, right? And then at level 5, we're able to appreciate a combination of feelings in ourselves and another kind of blend in the other person, like a patient that you're seeing. And that's what's going on with accurate empathy, right? When you're able to be in touch with your own feelings and feelings of the other person in a complex way. And so this is depicted in this nested hierarchy. In yellow, we're talking about implicit, the bodily responses. And we can think of a feeling at any given moment as a microgenetic construction going up the levels. So when this woman, the case that I presented, when she presented in the emergency room and had abdominal pain, she was functioning at this level. The week before, when she had grief, it was at level 3, okay? If you see what I mean. And the idea is that as you go up each level, it has a top-down modulatory effect. And this is kind of paralleled in the brain, right? And that's where the differentiation comes from. As you go higher and higher, more modulation, more differentiation and complexity. All right. Why do we have people talk about how they feel, right? I think this slide from Les Greenberg explains it. Les Greenberg developed emotion-focused psychotherapy. He's written 20 books on the topic, and he talks about this as the dialectical construction of the self. So people have emotional responses, and they feel it in their body. It's a bodily felt reference. It's the lived story. And then you put the feelings into words. It becomes the told story. You explain how you're feeling, and you create a mental representation of it, conceptualize it, and put it into words. When you do that, that then interacts, because it's happening in the brain, it's affecting the body, and that affects the felt experience. It changes the felt experience. More to talk about and more to describe, creating more mental representations going back and forth, or round and round in a dialectical cycle of meaning construction and the construction of the self, which less thinks of emotion as the core of the self. Okay, so I think one of the biggest moments in my career was when I was doing a research fellowship working with Gary Schwartz. We created the theory of levels of emotional awareness, and coming from a psychodynamic background, I figured we were done. We figured it out. We had a theory. And he says, well, now we have to see if it's true. Okay, what? Yeah. So let's create a scale, the levels of emotional awareness scale, which is a performance measure where we present people with emotion-evoking scenes, each described in 2 to 4 sentences, each involving 2 people. And we ask, how would you feel and how would the other person feel? Subjects can write as much or as little as needed to answer the 2 questions, and each of the scenes is scored on a 0 to 5 scale. So this is very different from the alexithymia scale, where people are rating themselves on how good they are. We're going to see what they produce, you know? So, for example, you and your best friend are in the same line of work. There's a prize given annually to the best performance of the year. One night the winner is announced, your friend. How would you feel and how would your friend feel? And so there's really no inference involved. We look at the words that people use, the words that are attributed to the self, the words that are attributed to the other, and we give level 1 for score for bodily sensations. I'd feel tired, sick, dizzy. Level 2, action tendencies are nonspecific terms like feeling good or bad, right? Then level 3, 1 specific emotion term. Level 4, 2 or more specific emotion terms for self or other, and a level 5 score when both are at level 4 or higher. Okay, so that's the basis for these findings. there are now 120 papers involving levels of emotional awareness that you can reach on our ELAS website. But you know, this is a strong psychometric instrument. There's good, excellent reliability and a lot of good construct validity information here. So it correlates in the moderate level with all these things, but not super high so that it's redundant, okay? Openness to feelings. If people are able to use more words when they describe how they feel, they're actually more accurate in identifying emotion in faces. They have a greater range and differentiation of emotional experiences. We did a study, ecological momentary assessment study. We found that the more higher people scored on the LAS, the more differentiated were their somatic symptom ratings in the moment, okay? Consistent. And also greater impulse control, consistent with the idea of top-down modulation as you go up higher in differentiation and complexity. And other findings that you see there. With regard to psychiatric disorders, lots of findings along the lines that you would expect. Patients with borderline personality disorder score lower. Eating disorders, lower. Substance abuse, particularly with impaired insight, lower emotional awareness. So a number of studies consistent with today's theme. Patients with somatoform disorders score lower on the LAS. And in treatment studies, there are now 4 different treatment studies published that emotional awareness scores can go up with intervention targeting greater emotional awareness. And a very important study published in 2013, study of psychotherapy treatment of panic disorder by CBT and manualized psychodynamic psychotherapy. The higher people scored on the LAS at baseline, the better they did in both modalities, not only psychodynamic, but also CBT. Okay, so, all right. So now I want to tell you about some studies we've done to experimentally test this, to test a hypothesis regarding emotion-specific mental representation deficit in the context of somatoform disorders. The hypothesis being that somatization may arise due to a deficit in detecting and processing internal emotional bodily signals that is converting implicit emotional responses into explicit mental representations of emotion. How might we test that? Well, an exteroceptive task, where people are looking at stimuli that we present to them, that may capture this deficit is one in which emotion cues are presented as actions so that in animated figures, so that the emotions may go undetected, but nevertheless are easy to detect and describe. And this will become clear in just a moment. Can you, I'm not sure exactly, oh, here we go. Just touch it. Okay.
You can even touch it.
Okay.
Yeah.
All right. So, here we go. I'm going to bring it back. All right. So, all right. So the task here is we presented people with these 35-second animations, right? And we just asked them to sit back and relax, and then at the end, speak into a tape recorder and just describe what happened. So there's no information or instruction with regard to emotions at all, okay? Okay, so I showed this animation to a friend of mine who had just broken up with his girlfriend, and he said, that's the entire story of our relationship right there. Okay, okay. Now, these stimuli have also been used in a neuroimaging context, and so for neuroimaging, you know, the brain is processing shapes and movement and color. So this is a kind of control, right? And we presented these to the patients, to our subjects as well. And as you can see, it's random movement. There's nothing really going on, whereas in the other one, there's a story, right? And we think there's emotional content, and a lot of emotional content in the first one, and basically none in the next one, right? And then there was a third category that's kind of intermediate, called goal-directed, where there's two figures are moving together, like in dancing or fighting. Okay, so this study, first study published in 2010, done in Germany in psychosomatic inpatients in Germany, 30 patients, and then 30 healthy controls. And we found that the LAS scores were higher in the controls than in the patients. And we took the descriptions of what happened during the animation, and we used the levels of emotional awareness scoring system. And we found that during the theory of mind animations, that the controls scored higher than the patients, so that there was more emotional content that was, you know, appreciated. They were making the conversion from these movements to conceptualized emotions, right? So it was consistent with the idea that there's some kind of deficit in the patients. We followed up with another study to see if it applied to outpatients in the United States. And this is Cynthia Stonington, who's chief of psychiatry at the Mayo Clinic in Scottsdale, Arizona, where they get a lot of referrals for patients who basically have physical complaints that, you know, can't be handled under routine circumstances, and many of these patients have somatoform disorders. So we were able to find 29 patients who had conversion disorder, 30 patients who had functional somatic syndromes, mostly fibromyalgia and irritable bowel syndrome. And then we had medical controls who had pain at the same level as the patients. But these were, the doctors judged the pain that they had to be consistent with the objective findings in their disorder. And so here are the results, and I'll kind of walk you through it. So in this study, unlike in the one in Germany, we had the random movement, and this is the theory of mind animation that you saw, the first one. Okay, so let's look at the control subjects, and you see that the numbers go up as you go down because there's more emotional content in the animations, the most in the theory of mind, and there seems to be some content here in the random movement. I'll now direct your attention to this, which is conversion disorder and functional somatic syndromes, and actually they don't differ, which was a surprise to me, because we thought that there might be a difference. Maybe conversion disorder might be more severe, but that was not the case. Point out that in all three cases, the controls scored higher than the somatic groups, the conversion and functional somatic syndrome groups. But what was really amazing to me was that there was a significant difference with regard to random movement, okay? So that healthy people kind of infer that there's emotional content present even if it's not there. You're predisposed to read emotions in situations, whereas patients with these somatoform conditions do not have that inclination to see emotion, and when the emotional signals are there in other people, they pick up on it to a lesser degree, and we think also they pick up on it in themselves to a lesser degree, and they're less inclined to think about emotion in themselves. Okay. So how much time do I have? 10 minutes, okay. So getting back to the question of alexithymia, is it an anomia or an agnosia? Because I think that the data that I presented really suggests that it's a kind of deficit, okay? Now, an anomia, this is a distinction in neurology. You know what an object is, but you can't name it, versus an agnosia where you can't recognize an object and you can't name it because you don't recognize it. So look at this thing. How many people recognize what it is, right? And you may be able to know that it's a musical instrument. You may be able to hear in your mind's ear what it sounds like. You may know that Stevie Wonder and Bob Dylan played it, but you may not know the name for it, okay? So you've recognized what it is. But somebody with agnosia has no idea, says something with teeth, okay? So it's a recognition failure. The perception is intact. You see the elements of it. It results from a breakdown in the link between perception of an object and stored knowledge about it. And so we wrote this paper in 2015 on affective agnosia, and Freud is in the title. It's an expansion of the alexithymia construct and a new opportunity to integrate and extend Freud's legacy. Why is that? Because Freud was the one who coined the term agnosia in 1891. He was a neurologist before he invented psychoanalysis. He says for disturbances in the recognition of objects, which Finkelberg calls asymbolia, I like to propose the term agnosia. Freud's idea was that, you know, when you see this harmonica and you have the word, but there's also this intervening mental representation, this idea about it, all the things you know about it, separate from the word, okay? So how does this apply to alexithymia? In the domain of emotion, the perceptual stimulus is interoceptive. It's that bodily response, the implicit visceromotor behavioral emotional response. In this formulation, if it's just the word, it can be mentally represented, experienced, and known. Alexithymic individuals have difficulty describing and cognitively elaborating what they perceive, experience, and know. They experience emotion in the same way as anyone else. Our patient at the very beginning experienced grief. She just couldn't put it into words. Here's an agnosia version. In affective agnosia, it's a failure to mentally represent an implicit emotional response associated with deficits in experiencing, knowing, and describing one's own emotions. If you don't experience it, you can't put it into words. All right, why do we bother doing this? It's not just concepts. We really want to understand how this is working in the body. And we published this paper in a neuroscience journal because we said this is not just an analogy, this is a real thing. There are such things as agnosias. This is a supramodal agnosia involving a deficit in the recognition of one's own emotions. It's a failure of subcortical transmission to the medial frontal lobe to this particular area, which we know is a lead area in a mentalizing function. It's a failure to mentalize and mentally represent. Okay, why might that be important? Well, functional imaging studies show that this area here, the medial prefrontal cortex, participates in regulating vagal tone, the branch of the autonomic nervous system that has a braking action on the heart as measured by heart rate variability. This is a meta-analysis from a dozen studies where heart rate variability measures were taken along with functional brain imaging. And what it showed was that there was a positive correlation between greater heart rate variability and greater activity in this medial prefrontal cortex area. So what that means is that when you're more calm and relaxed, you're able to mentalize. When you're highly aroused and vagal tone is low, medial prefrontal cortex goes offline, okay? Okay, we can carry it further when we consider that the vagus is anti-inflammatory. So activation of the vagus nerve is anti-inflammatory. So if you are able to mentalize, you have greater vagal tone, your inflammation gets under control. Conversely, if you're not able to mentalize, you're highly aroused, you don't have much vagal tone, and inflammation is active, and that can promote pain, among other things. And we said that there's actually a kind of closed circuit that happens in affective agnosia where you have bodily arousal and you don't know what it's about, and that raises anxiety level and raises arousal further, and that's why people go to the doctor, because they think that they're sick. The way out of it is to engage these areas involved in mentalization and working memory and processing of emotional experience. So, somatization may arise because of a deficit in the capacity for or inclination to mentally represent emotions. Conversion disorder may arise from a failure of conversion from implicit to explicit emotion processing, potentially in contrast to Freud's hypothesis of conversion of affect to bodily symptoms through defensive processes such as repression and symbolic representation of the mind in the body. I'm not saying that doesn't happen, but I want to emphasize a deficit model, right, which is quite different. And it's why it's such a difficult clinical problem to treat. Now, in Germany, they've realized that it's not only beneficial to the patients, but it's economically beneficial to get patients with somatoform conditions who are so incapacitated that they can't work. It's worth bringing them into treatment for 3 months to get them functioning again and back to work, and it pays off, right, in the long run, offsets the cost of treatment. So in these psychosomatic units in Germany, they do psychodynamically oriented individual and group therapy, body-related therapies, art therapy, music therapy, and medication is needed. The therapists talk together, they compare observations, and intervene with the patient in a coordinated fashion to facilitate the transition from implicit to explicit emotion processing. So it's facilitating this transition from implicit to explicit. So to conclude, these are the take-home points I hope you'll take with you. Lower emotional awareness is associated with the somatic presentation of distress. Early adversity is a common context for impaired emotional awareness. Performance-based assessment of impaired emotional awareness has distinct advantages relative to self-assessments, particularly in severe cases. Affective agnosia provides a new perspective on how to understand body-related states associated with an affective deficit, and we can understand self-injury, somatization, acting out from this perspective. Expanding mental representations of emotional states and linking them to bodily experiences, promoting the implicit to explicit transition may be key to successful treatment, and I think that that's what a lot of our talks are going to be about today. So that concludes my presentation. I want to thank you very much.